My case is about coronary dissection. I will get in quickly. My patient is a 37-year-old female patient, known diabetic since she was 12 years old, hypertensive, married with no child. Her body mass index is 28.7 kilograms per meter square. She presented to our ER with acute onset of typical anginal chest pain of 2 hours duration. Her ECG showed picture of acute extensive anterior myocardial infarction. The case was accepted by us for primary PCI, and she was admitted to our cath lab within about 45 minutes of her presentation. Her coronary angiography shows total LED, diseased LCX and OM, and the RCA showed 2 lesions, one proximal and one distal, nearly subtotal lesions. Primary PCI was performed to the LED using an assay software, 220 balloon, and an Onyx stent 3x26 was inserted with Tamiflu 3. However, the patient was still in severe chest pain, so we decided to perform the RCA actually. So with the same software, we introduced it and inflate the distal lesion with the same balloon I used in the LED 2x20. However, dissection occur, proximal and distal. Then for here, I decided to put stent in the distal lesion first for 3 reasons maybe. One is that I believe that this is there's 2 entry sites, one proximal and one distal, and maybe overconfidence that the wire was in place. After inserting the proximal stent, the patient developed VF, cardiac arrest. Immediate CPR was done, and after inserting it, there was no flow. I decided to put another stent distal to the distal stent because of there might be a distal dissection also. Of course, you know that the wire is the most important and precious thing, but yes, it happened. The wire was pulled away. Fortunately, I introduced another run-through wire, and it was in the true lumen. This time, the stent was introduced distal to the distal stent. And the distal flow was good. Another stent was put in the mid segment of the RCA. Here, the patient was resuscitated and gained her circulatory support. And this is the final results. 2 hours later, the patient was hemodynamically stable and with good urine output. And she was extubated from the mechanical ventilation with no chest pain. My take-home message is that the coronary artery dissection is one of the serious complications which may occur during coronary intervention. Keeping the wire in place is crucial to save the patient and minimize the time of the procedure. Using other tools, of course, as IVUS and microcatheters can facilitate the procedure and optimize the management. Thank you so much. This is my case.